presentation. My name is Angela Odoms-Young. I'm an associate professor in kinesiology and nutrition at University of Illinois at Chicago. And I also serve as associate director for research and education in our Office of Community Engagement and Neighborhood Health Partnerships. I'm passionate about health equity, and today I'm going to talk about health equity. I get really excited about, of course, not excited about racism and discrimination, but excited about looking for and identifying opportunities to close the gap and address the determinants of these issues that have persisted for many years. So thank you, and I look forward to the conversation today.
I think Valerie said we'll talk in reverse, and then so my name is Iyabo Obasanjo. I am an assistant professor at College of William and Mary in the Department of Health Sciences. I teach public health courses. My PhD is in epidemiology, and I am interested and research social issues that affect health outcomes. Like Angela, like Dr. Odoms-Young, I'm passionate about health equity, both in the US and internationally. And I'll hand it to Mo.
Thank you, Dr. Obasanjo. My name is Mo Barbosa. I serve as Director of Community Engagement at Health Resources in Action. We're a public health social change organization. One of the other hats I wear is the chair of the Men of Color Task Force for the city of Cambridge in Massachusetts, where we have been focused on these issues of inequities for the last 25 years. Part of my work is, and part of my passion is around racial and health equity, and also do a lot in violence intervention and prevention. And those in this country at least have lots of overlaps. I'm going to thank you for the opportunity to be first. It's very seldom that I start things off this way, so I'm going to make good use of the time that we have. I'm going to do a dangerous thing first, which is attempt to share my screen. So I just ask for your grace and patience as we make that happen. And then we're going to dive right into really thinking about racism as a pre-existing condition and how that has shaped where we find ourselves vis-a-vis COVID-19 in America. So, hopefully you can see the slide there. Okay, wonderful. So we'll get started. This is actually a street sign in Philadelphia looking at addressing COVID-19 in that particular city. What we know is that COVID-19 has had a disproportionate impact on the Black and Latino community. Black and Latino workers are overrepresented among the essential, the unemployed, and the dead. This is a quote from an article in The Atlantic, and it really captures for me what we're dealing with. At the same time that we are holding up this group of people who are essential workers, who are treasured for all that they are doing, we are also seeing that many of them are disproportionately affected by the thing that they are trying to fight. Washington Post did a survey that looked at the disproportionate impact of unemployment, people being laid off, and those who are being laid off being disproportionately Black and Hispanic. And this is where you would catch folks in the formal economy, the informal economy, the folks who are doing construction work on the side and so forth. Those numbers are even greater. And this mirrored what was happening in the early part of the pandemic across the country, that Black and Latino workers were losing their jobs at higher rates even when they were overrepresented in the essential workforce. One of the telling statistics about that overrepresentation was that about 30% of the nurses, the vocational nurses working in hospitals and nursing care facilities and so forth, are African American, when the population in America is only 13% African American. So we have an overrepresentation in the workforce that's actually being in contact with the virus. And then the Latino population also is disproportionately in the agriculture world. And if you think broadly about agriculture, that includes the meat packing plants and all the food facilities. And in those spaces, they've also been ravaged by this disease. Overrepresented in the dead, and this is something that early on we really had to fight to bring to the fore, that not only was it not being recorded everywhere in terms of who were contracting the disease, but also who was dying from it. We weren't catching race and ethnic backgrounds. And so early on, there was a feeling that there was a disparity, but there wasn't really proof. When you spoke with doctors and medical facilities, they talked about who they saw, and they saw an overwhelmingly Black and brown population that was showing up very, very sick, and oftentimes way beyond where they could really help them to come back to full health. Stepping back from that, and with a little bit of time, we were able to capture some of that information of race and ethnicity. At the national level, there was quite a bit of advocacy in the Senate. In certain states, local advocates were able to also push public health departments and state departments of health to publish the information. And so one of the early studies was by AmFAR, and what they found that in the 22% of US counties that where there's a disproportionate share of African Americans. And so if you think about this, this would be counties where roughly more than a quarter of the population is African American. In just those counties, which is about 22% of US counties, more than half of the coronavirus cases for the country resided in those 22% of the US counties, and 60% of the deaths total resided in those countries. And so in those counties. And so you have a location that has a high rate of African Americans having the greatest number of cases and unequal burden of the deaths. So this is a map that just kind of highlights what I'm talking about, is that if you notice in these black spots, the kind of darker areas are where there's a high proportion of African Americans and a high proportion of COVID cases. Some of these are the places that you're going to know. Obviously places like Chicago and Detroit, just outside of St. Louis, and Washington, D.C., but also some rural counties all around across the South. And where you see this darker blue are also places where there's a kind of a medium level of African Americans and a medium level of cases. What we don't see in this is where there are also high rates of COVID cases and not African Americans. And so some of that you can notice in these darker reds, where those counties don't have an overrepresentation of African Americans, but also have high cases. Many of these especially have high rates of Latino populations. And in this little corner here, where Arizona, New Mexico, and Colorado and Utah meet, is also a place where the First Nation and Native Americans have high rates of population and high rates of COVID. But we see this big stretch of blue here where there's a disproportionate impact. Health equity forces us to ask the question why. My colleague Angela will dive into what health equity is. I'm going to just give a quick overview of how this is impacting us, but it always asks the question why. So why is it that we are seeing this disproportionate impact in a population, with the assumption that there is not something wrong about that population to begin with? And that's one of the things that we really have to do, is remove the pathology that would blame the people for what they are suffering. And so really digging into what is happening in the communities that these folks are in, and why is it that they are at greater risk. Folks have seen this chart. I've seen it for way too long. This is life expectancy. So in America, we already have pre-COVID. This is 10 years before COVID. We already had this disparity in life expectancy in terms of Black males and Black females versus white white males and females. So this was already in place to begin with. And it also forces us to think a little bit about why does this persist? You've got this is a good 50 years almost of time, or 40 years of time. And we see a little bit of progress, but not a reasonable shortening of this gap between Black male and white male life expectancy. And one of the things that has always stuck with me is that, and something that I first noticed in the 90s when this chart really finally got into my head, was that African-American men were dying before they were at the age of retirement, that their life expectancy was shorter than when they would be eligible to retire. I want to just bring it down to Virginia. For those of you who are in Virginia and care about Virginia, this is infant mortality rates by race and ethnicity in Virginia. This is from the March of Dimes. The 2015 to 2017 average for Black families, the infant mortality was about twice that of the white infant mortality for white families. And importantly, that this really is about the same place it's been for the last 20, 30, 40, 50 years. We've gotten a little bit better, but better is still more than twice as bad as the experience of other folks in the community. And if you notice, this singular group that is suffering at a worse rate is also dragging the rate for the state as a whole. This repeats itself across the country. I was in Kansas. These numbers were even higher. I work in Massachusetts. It's about 2.3 times as high. This persists, and it persists regardless of socioeconomic status. So it doesn't matter if you are in a wonderful tree-lined suburb. It doesn't matter what kind of job you have, or if you're getting the best health care. We are still seeing these same differences in health outcomes. And this is the reason why we have to look beyond the experiences, or look beyond the attitudes of the people involved, that there is something going on beyond what individual choices could create. Quick quiz: which country had a lower infant mortality rate than African Americans in Virginia in 2015 to 17? There is a button at the bottom of your screen that allows you to choose a reaction, so you can put a thumbs up. For those of you who think that it is A, Cuba, let's see if you could give us a thumbs up and see how many folks are in that group who think that it's Cuba. Anybody? We've got a few thumbs up for Cuba. Okay, all right. Let's see how many folks think that it's Taiwan. Taiwan, let's do a thumbs up for Taiwan. Let's see how many pop up for Taiwan. All right, all right. What about Portugal? How many folks think it's Portugal? All right, we've got a few thumbs going there. All right. I just want to mention that we're going to hold off questions until the end, just to make sure that all the presenters have a chance to go through their presentations, and then we'll do questions. So please put questions in the chat, and we'll make sure that we come back to them. For this particular one, this is actually, all of them had better infant mortality rates than African Americans in Virginia in this time span. All of these rates were much lower than the rate, the 10.8 rate for per live births that we had in Virginia. But this isn't the only space where we see this disproportionate impact. And so, as I mentioned, racism is a pre-existing condition, and we see racial inequities across the board. Using a health equity lens really asks us to do a couple things. One, are we willing to see it? Are we willing to look at the data and really see the inequities that exist there? Are we willing to disaggregate the data so that we can look in on the experiences of different groups? And then, do we have an analysis on race, power, and poverty? Do we take into account the interlinking pieces between race and power and poverty and how they put particular populations at risk? And do we have an analysis on who has power to make changes in that? So I just want to share some of the inequities that Virginia has seen. And this comes from an article from the Richmond Times-Dispatch paper. And so they put together this information. I just kept the sources there. We'll go quickly through these. I think folks are familiar with them. Inequities in mortality rates for mothers. So we talked about infant mortality. This is mortality for the moms. The Black maternal mortality rate is double that of the white rate. Life expectancy. And so while this looks pretty good in terms of about 4-year difference across the state, one of the things that the paper in Richmond talked about was that within 5 miles of downtown, that difference was about 20 years. That mirrors a lot of what we see across the country, that affluent white areas and poorer African-American areas tend to have a really wide difference in life expectancy, often in terms of decades, and 20 to 30-year differences are also very common. Third grade reading. Black third grade readers are proficient at about 57%, Hispanic third graders 55%, while white Virginia third graders are at 80% proficient at third grade reading. And this is important for those of you who are wondering why third grade. This is where, while you're still learning how to read, starting in 4th grade, you are reading to learn other things. And so if you're not proficient in reading, it makes it really hard to learn after that in 4th grade and beyond. And it's often a predictor for whether or not folks are going to succeed in school, drop out of school, etc. Sorry, that was life expectancy. Housing, as the population of the white population in Richmond increases 10%, evictions go down by 0.9%. As the rate of Black population increases 10%, the eviction rate goes up by 1.2%. And also the African-American neighborhoods are often undervalued compared to similar households in similar houses in white neighborhoods. The school to prison pipeline, this is also another space that we see Black students, and this repeats what we see across the country, that Black students receive more severe discipline. They are often also being disciplined for more subjective things. So the white students would have really objective rule violations, while the Black students would get severe discipline for being obstinate or being not willing to answer a question or talking back, as opposed to violations like physical things that the white students would do. Poverty rate, the Black poverty rate, and this is pre-COVID, is at a much higher rate there, more than double, and we would probably see this even higher in these dates. Arrest rates, and this is about a little bit more than double the Black arrest rates versus white arrest rates, and this is the same pretty much across the country, that we see that not only are Blacks more likely to get arrested, they're more likely to be engaged by the police to start with, stopped by the police, searched by the police, arrested, charged, adjudicated, receive a sentence, have that sentence be in jail, have that sentence be longer compared to whites for the same infractions with the same background. And this shows up in the prison system there, that the previous rate was a little over twice as many folks getting arrested, but then when you look in the actual imprisonment rate, this is on the order of 4 times, more than 4 times greater there in terms of the Black imprisonment rate. And it's not just Virginia, this is across the country. Just because we use the terms health disparity, for those of you who may not be versed in this, and just to make sure that we're level setting, it's a difference in incidence and prevalence of health conditions and health status between groups based on many factors, but race, ethnicity, socioeconomic status, orientation, gender, geography, disability, or any combination of these. We talk about health inequities, however, to really mean the difference in health outcomes that are systematic, avoidable, and unjust. And if you forget everything else I've talked about, remember that inequities are unjust, that these things are avoidable and they're systematic across the board. So One of the things that we want to really focus on is that this really comes from what we find ourselves in today is this underlying structural racism that's having an impact on the populations that we are seeing having higher rates of COVID disease and also dying from it. That the reinforcing systems around housing, education, employment, earnings, benefits, credit, media, healthcare, and you could go on and to include criminal justice and others, that these have a negative effect on the lived lives of people of color as well as their health outcomes. Our friends at the Racial Equity Institute, in their wonderful article called The Groundwater Approach, really posit that our racially structured society is what causes racial inequity. There is no other cause for this. This is baked into how our society has been structured and our communities have been founded. We were mentioning earlier that the 400-year anniversary of the first African Americans coming to the United States as enslaved people was last year, so 1619 to 2019. From that moment forward, we have created a system in this country that posits that one group is advantaged, and that is the white group, and one group is at disadvantage in every system across the board. And what we see is that repeats across all of these. So racial inequity ends up looking the same across different systems. Socioeconomic difference won't explain those inequities, so you can have money and opportunities and houses and so forth and still experience those inequities. And that these inequities are, they're not the behaviors of individuals. These are really caused by systems, and our solutions then have to be at the system level. How unequal? This mirrors pretty much what we saw in all those statistics about Virginia. African Americans 2.3 times more likely to experience infant death, 1.9 times more likely to die of diabetes, 3.7 times more likely to be suspended, 7 times more likely to be incarcerated as adults, 5 times more likely to be denied a loan from a small business. All of these play a major role in the experience of population and the disparities that they face, and then the inequities that are visited upon them. This is for America as a whole. This is just mapping those inequities in terms of what we see in Massachusetts. And if we did this for Virginia, it would look very much the same, where that blue line is the rate of worse outcomes vis-a-vis the outcomes for whites. So how many times worse are the outcomes for African Americans? And our friends at Racial Equity Institute who put this together, they do these for each state, and these look very much alike. Alabama, Maryland, and Massachusetts have peaks in different places, but the map looks exactly the same, where the blue line will never cross the red line. Never will the outcomes be at an equitable level for Black and whites across all these different systems. And if you think about health, education, criminal justice, housing, economic systems, all of these persist. So I just want to use my last few minutes to go really back to COVID and how and why are we seeing this, and where do these inequities make this worse. So living conditions, ethnic minorities and racial minorities tend to live in densely populated areas. The racial segregation that has been caused in the United States makes for these to be areas that are further from grocery stores or medical facilities, oftentimes poor housing stock and more segregation. So while we're asking people to social distance, to stay at home, they're going back to really dense places. 6 people living in an 800 square foot apartment doesn't give you as much social distance as 6 people living in a 3,000 foot home. And so part of what we're seeing is the result of that, those living conditions that put people at more risk. Also multi-generational households, so older folks who are more susceptible to the disease are nearer to people who are younger, who are also still working in those overrepresented jobs, and so bringing the disease even closer to those populations. And also that there's an overrepresentation in congregate housing, such as jails and prisons and detention centers. Working circumstances, so critical workers in essential industries. And, we are used to celebrating the doctors and nurses at hospitals, but there are 300 other jobs at those medical facilities that are working with patients. Many of those are also being helmed by people of color, Hispanic workers and African-American workers who are being, whether they're the nurse's aide or they're doing, radio technology, or they're doing the sweeping of those rooms. All of those jobs are putting them in contact with the disease. And again, they're going back to communities where they're putting their families and the people around them at higher risk. Hispanic workers are, as I mentioned, also are doing a lot of work in agricultural spaces where they are even more exposed to being with lots of people who then communicate the disease. And also there's a lack of paid leave. So even when people feel like they shouldn't be at work, the motivation to put food on the table and pay the rent and keep from getting evicted puts people at work and keeps putting them in risky spaces. Last but not least, I just want to mention that the underlying health conditions for these populations and the low access to care are real factors. And so one of my colleagues, Claude Jacob, who's the director of the Cambridge Public Health Department, said that basically COVID is an accelerator. Whatever was wrong with you before, it just ramps it up and accelerates it. And so if you had these serious underlying medical conditions before, if those were prevalent in the population, COVID comes around and just jump starts those and sets them to the extreme. And that's what we've been seeing in the African-American community, that they are already stricken with many diseases, and that not having trust of the healthcare system, and those things put them at risk already, and then COVID comes along and sends them over the edge. That was the fast-talking Northerner version of today's session. So I'm going to stop sharing and send it back to my colleagues who will take us to the next step.
Okay, Mo had already talked about, oops, that's not where I should be. Okay. Mo had already talked about some of the things I'm going to talk about, but there will be an overlap in general from me to, between Mo, me, and Dr. Odoms-Young. And the first thing I want to talk about is that, is there really a disparity in COVID-19 outcome? And I'm going to start with this real-time slide that goes to the University of Berkeley, California at Berkeley, where they are they're looking at all the areas and for each state, where is there an over-representation of minorities in the cases of COVID-19. And when you look at this, the redder the state, the more there is a disparity. North and South Dakota are the only states where there's no disparity, and that is just because there's so few minorities there and there's so few COVID cases as of present that there's really, the data is kind of scant. The overrepresentation of minorities in the Eastern United States and the Midwest tends to be overrepresentation of African Americans, Black Americans. On the West Coast and the western part of the country, it's mostly Native Americans and Hispanics. And in some parts of the East too, some in the South, it tends to be also Hispanics and African Americans. When we go down to this on this website, this first graph shows the representation of the different population of the different races and ethnicity in the total population in the US. If the cases of COVID were the same as in the population, these two graphs will be the same. And as you can see, they're not. The white population is underrepresented in the amount of cases. The Latinx population and the Black population are overrepresented. And the Native American, which is it's about 1%, rises to about kind of 2% here. But so those three groups, and of course others as well, are disproportionately represented in the cases. When we get to the deaths, it's deaths actually then make it even more interesting, or if you're an epidemiologist and you like looking at data. The white population death is actually now getting close to the representation in the population. The Latinx Hispanic death rate is lower than their rate of getting COVID, while the Black population death rate is higher than the rate they're getting COVID, which means that the Latinx are actually not dying at high rates, although they're getting it at extremely high rates compared to their rates in the population, almost twice. The reason for this is that the Hispanic Latinx population tends to be younger. If you look at the population demographics in the US, the Hispanic Latinx population is younger than both the white and the Black on their median age and average age. The reason being, first, there's a lot of immigrants in that group, and only healthy people tend to migrate. That's anywhere in the world. And two, the birth rate is a little bit higher than either of these two populations. So what is the main factor for the higher death rate in the Black community? Most of it has to do with underlying conditions, underlying health conditions. This blue map is the distribution of population in the US. And as you can see, New York, Florida, Texas, and California are the 4 highest populated states in the country. So the bluer the state, the higher the population. The reason I am bringing this up is because of my next slide, looking at location and density. This graph, I hope you can see this too. This is the states with the highest cases of COVID-19. So a bigger circle means more COVID-19. This is New York, Florida, Texas, and California. As you can see, the highest populated states have the highest number of cases. This is easy, and then of course, if you look at the largest bubbles, it goes with the 10 highest populated states. The reason for this, of course, is because COVID is a human disease. It's looking for humans to infect. So it goes to where there are more humans. And so where there are less humans, there'll be less COVID. And there's less COVID to transmit, mostly because the contact with other humans is less. So that explains why those states have the highest cases. This is a graph of the US showing the 10 states with the largest African-American population. If you put this map over the COVID cases, over the population, these 10 states will also be the states with the largest number of COVID cases and with the largest population. What this says is that African-Americans tend to live in highly populated states. That makes a lot of sense for 2 reasons. One, those states tend to have more jobs. Those tend to be the states where is actually have lower unemployment, have better job opportunities. But also, there's a tendency for African Americans to live where other African Americans live for safety in numbers, just because of the history of violence and some of those other issues. So you find that in bigger states, you have more of African American population. When you overlap that with a disease like COVID, that is where that is part of the reason. So location is part of the reason we have the excess case, but it does not explain everything. And I'm going to get into some of the things Mo has talked about. Essential workers. I think this first statistics, Mo also mentioned it. 30% of CNAs and LPNs are Black. Blacks are 13.5% of the population, but are disproportionately represented in essential and critical worker population. What that means is that the exposure is very high. The exposure rate, because when some of us could work from home, they couldn't. They were actually still facing the public. And also Latinx and African American population tend to work more in those service jobs. Again, part of it has to do with education and all kinds of other things in the society that limits the ability of these two groups to actually be able to get professional jobs. So what you then find is that tourism industries, while you're meeting people, bus drivers, all this leads to overexposure of the population. And when you look at doctors, a study has actually found that doctors have less rates of COVID-19 compared to the general population, which is amazing because they're dealing with patients all the time. But then by the time a doctor actually sees a patient, that doctor is all geared up, has all the PPE they need to be safe. Most of the time, the people seeing patients without adequate PPE are the CNAs, who are mostly in nursing homes, and the LPN, the licensed vocational nurses, practical nurses. And so the higher you go, the less Latinx and African-American population you get, but then the more protected those workers are in terms of their ability to protect themselves from the disease. Mo has talked about this, the wealth gap. I'm not going to spend too much time on it because I think we all know this is the net worth of the white family and the Black and Hispanic family. It has not changed much, and it's still significantly less. Why is this important? Because health is associated with wealth. This is expected life expectancy from 40 years of age. And why we're using 40 years is that we're trying to say, okay, let's just discount your parents' wealth, your own wealth at 40, and then we look how long you'll live. No matter what at every income, what this is showing is that at the lowest income, we're most likely to die before you die earlier based on your income, and it never stops. The more money you have, the longer you tend to live. This stops at $2 million. So if you are able to even make longer, you can buy health. And in my classes, I tell my students, and they're always shocked, health is a commodity and we treat it as if it isn't. People that are richer live longer. And even if you look at the households you were born into, in those households, the household you are born into, the income of that household can determine your life expectancy too. We can actually tell. If you then make more money, you increase your life expectancy. So the fact that African American and Latinx life income is so low is part of the issue going on. So I talked through. This is the one I was talking through about expected life expectancy from 40 years on, and I kind of explained this. And women live longer, but the more income you make, the longer you'll live, even from 40 years on. The slide I was on, this is looking at unemployment, Black unemployment versus white unemployment. And this line at 2 is if Black unemployment is twice that of white unemployment. Since 1972, most of the time, Black unemployment has been over 2 times that of white unemployment. A few times it has actually been on the line. For the most part, it's about 2.5 to 2 times that of white unemployment. Why is that important? That's important because of my third reason here, which is access to health. Access to health in the US is determined by employment. So if you are unemployed, you do not have access to health, as we know that. Yes, there's Medicaid, but underemployment is actually what is the main driver of not having health access to health. Is that if you have an income of a high income and no income, you'll probably have access to health because of Medicaid. But if you are a little bit above the poverty rate, then you do not have access because those jobs generally do not come with health insurance. The problem with that is that most parts of the world, one of the ways they've reduced health inequities is to not have health access be based on employment. It's a way to actually continue health inequities because those who have then keep having more. So that is why the unemployment data in terms of health is very important. This is uninsured rates. The Hispanic rate of being uninsured is the highest in the country, although the rate has been falling for everybody, mostly due to affordable health, the Affordable Care Act. That has changed in the last few years because the rate of uninsured has started to rise from around 2018 on. But even now, it's about twice or three times that of the of every other group, that of the Hispanic population. Part of that has to do with the fact that a lot of laws have come into place to disenfranchise recent immigrants from having access to health. Part of it too is that a lot of the jobs, everything from lawn care and things like that, are jobs that you do make an income, but the income does not provide you with health insurance. It's kind of jobs in which you get an income that is not too bad, it's not low, but it does not give you access to health. Underlying health conditions. Why do we have, what are the causes of underlying health conditions? Like I mentioned, Moad talked about this. There's the structural racism and the constant microaggression. I'll talk a little bit about that later on, just briefly. The lower levels of education. Again, the education one, I'll mention it a little bit, because education in the US is uniquely paid for by residential taxes. It really does a disfavor to minority groups because, of course, minority groups tend to live together because of safety and because of all the other issues that make them have low income. When you pay for education with residential taxes, you're essentially saying poorer people will always have a lower level of education than richer people who also tend to live together. Lower access to food with adequate nutrients, the issues of food deserts, which is Dr. Odoms-Young main area of research, barriers to exercising. In the news, so we've had this year, so at least several cases of young Black men exercising. There was one case in which the young man was killed. The barriers to just kind of enjoying nature. People asking you why you are there. So of course, when that is the case, it puts a barrier. You have to think about whether you can actually go out there and exercise. And those are some of the high obesity rates. That has to do with the nutrition, the lack of exercise, and the overwhelming stress. Basically, we know that the stress hormones control obesity rates. And when people are under a lot of stress, their ability to actually metabolize fat. Poverty itself is a stress when you remove racism. So when you now had racism and poverty rates high in a segment of the population, you know that the level of underlying conditions will rise. Stress is a big factor for a lot of chronic health conditions. Environmental issues. We know that environmental justice is a big issue. Dump sites for toxic waste tend to be located in minority areas of the country. This has been found over and over again. Most of the time, what this leads to is high rates of asthma, high rates of other metabolic diseases because there are chemicals in the air that these minority groups are breathing from those dump sites. And of course, Mo has talked about this, the over-policing and excess incarceration, especially of the Black population. All that leads to health issues. Incarcerated people have higher rates of HIV, higher rates of hepatitis, higher rates, and then just the risk of over-policing and the stress it causes on not just the victim, but the whole extended family. Okay. I can't move to the next slide. Hello, can you see my slides?
We can.
I'm not going to, this slide here, I was going to link up to the Department of Health and Human Services site that just shows the disproportional rates of some diseases among the African American and sometimes Hispanic population, diabetes, heart disease, and things like that. But because I don't want to lose you guys again, I'm just going to skip that because that's all it shows. So, the way people have thought that these inequities can be managed is to have Black people be successful, right? Being successful will kind of take this away. What has been found actually, and I have some of the, not all, but some of the references here, is that actually it doesn't help. It might actually hurt. Why does it hurt? It's because what has been found is that the more achieving you are as a Black person, the more you are in a space that is non-Black, and the more people actually react badly to you, and the more microaggression and the more insult. Black doctors have had cases in which they go into a patient's office, a patient's room, and the patient is like, "You're not a doctor, you can't touch me." Doctors thinking they're janitors, but nobody ever thinks the janitor is the doctor if you're Black. So Black lower level workers actually have less stress in terms of being those kinds of situations. So that actually the more you go up as a Black person, the more those microaggression and those kind of insults you get. And your body reacts to those by increasing the stress hormones, by increasing some of the factors that and that then over extended period of time, inflammatory cytokines and things like that over time lead to higher rates of heart disease, diabetes, and all that. I'm going to epigenetics. This has been found in Jewish and African Americans. Stress from 2-3 generations before you. I think they've been studied up to 2 and 3 generations, and it might go further. When those stresses, especially real extreme stress, like from the Holocaust and from slavery, when certain stress genes are triggered by those events, it takes several generations for it to go, and we don't even know when it ends. For African American population, what that stress turned on DNA has been found is that it changes the ability to metabolize fat, so that stress-related obesity changes how that. And for in the Jewish population that survived the Holocaust, when it has been studied of children that of survivors of the Holocaust and children of Jewish people with the same Jewish ancestry that did not go through the Holocaust, that DNA for anxiety and management of stress has also changed. And so these are really, really things that we're finding, that the absolute stress we put humans through has an effect for several generations to come. So I want to talk about some of the things that are critical to kind of solving this. Health insurance being linked to employment is really, really an aberrant way to solve a social issue of improving healthcare. It connects location to employment, to underlying conditions, to so many things. So if you cannot one of the things that needs to be looked at is how healthcare is accessed by the whole population. Again, you take it from, if one group has underemployment or unemployment, this is actually a race-neutral solution, in that most countries in the world have kind of removed health access from income and employment as a way to reduce social disparity within their population. The other one is education. Education is so vital to income, to where you live, to your ability to write. And when you pay for it by residential taxes, again, you've kind of, this is also another race neutral solution, in that you've removed that inequity that will make certain people continue to have worse income and worse health outcomes, no matter what people personally do for themselves, because again, where your parents are, and we know the injustices that have made those parents be where they are, and education is a way to pave the way for the next generation. But if you can only go out to the school next to where your parents live, and it's the worst school in the area, those disparities are never going to go away. The Gini coefficient is what we use to measure income inequality. And the Gini coefficient versus life expectancy has an inverse relationship. And this is on a country level. So the higher a country has in income inequality, the lower the life expectancy in that country. So countries with higher social and income inequality have worse life expectancy for the population. And I'm not going to show the, I actually don't have the slide for the country. The US, in terms of high income countries, has one of the highest income inequality. So why are we seeing the things we see? COVID is devastating the communities that we see. This minority community, Black, Latinx, Native American, and actually refugee communities too, because we find that in the meat packing industries, it was the Latinx and the recent immigrants, refugees that were infected in those meat packing industries in the Midwest and the West that then took it home to their families. COVID is devastating those communities because of the economic and social inequities that are kind of baked into the system already. So really, the fact that COVID-19, America has a raging COVID-19 outbreak is really because of the underlying social and economic inequality. And if we don't start to look at that problem, COVID is just a tip of the iceberg, because we don't know. In the 21st century already, we've had more infectious disease outbreaks than we had in the 20th century. In 20th century, we kind of conquered infectious disease, but they're coming back. So we really need to deal with those underlying conditions. The underlying condition that COVID found in minority populations that made it rage is this complex issue of socioeconomic issues: income, education, access to finances, incarceration, and then pervasive racism. That really both structural and individual racism that leads to chronic stress, the over-policing, and all these issues are why we're seeing the data we're seeing. And I'll hand this to Dr. Angela Odoms-Young.
Okay, great. So I'm going to cover probably some things that were talked about already, but maybe present an additional lens and talk about the implications of social and structural determinants of health, which is sort of the same story that I think that we are probably starting to get probably even before the two presentations, but definitely as it was described very well within Mo's presentation and in Dr. Obasanjo's presentation. So I'm going to talk a little bit about this in the context of pathways. We think a lot about systemic racism and social inequity, but what is the pathway? And one of the things that I'm interested in my work is really disrupting that pathway. As Dr. Obasanjo mentioned, that this is a legacy of things that have happened over 400 years. And I think Mo also mentioned that, Mr. Barbosa in his presentation. But how do we disrupt that in 2020 when it's something that not only happened in slavery, but it's persisted since that time? And we're seeing that in the story of COVID, which is not an unusual story when you look at the inequities that already exist. So even the CDC acknowledges that COVID is embedded in this idea of longstanding systemic health and social inequities that put some people more at increased risk for multiple things, but in this case, COVID or experiencing severe illness regardless of age. So they documented where non-Hispanic American Indian and Alaska Native persons have approximately a 5 times hospitalization rate from COVID as non-Hispanic white persons, Black persons a 5 time hospitalization rate as compared to white, and then Latinx populations are 4 times the hospitalization rate as it compares to white persons. Another disparity which is not highlighted within this that we don't talk about as much is when we look at low-income whites. And so what's interesting about race is that you have racial discrimination and in many cases income discrimination layered on top of that. But that doesn't mean income discrimination doesn't exist alone, and racial discrimination and inequities don't exist alone. Commonly what you have, and sorry, I know you hear barking dog. And so in the context of African Americans, you commonly have this layered effect where you have an impact from income inequality as well as this impact of racial inequality. So as was mentioned, this manifests itself in inequities in health outcomes that start from not only birth, but conception. If you take a life course perspective, we talked about infant mortality, maternal mortality, but life expectancy really starts when you're conceived. And so this was data that was came out of a Robert Wood Johnson Foundation supported project that VCU did. And this is the Chicago train line. So the our L line, and it shows life expectancy across really very few stops. You see inequity. So the difference between Lincoln Park as compared to Washington Park, which is predominantly African American, you see that difference in life expectancy even within short distances. So as was kind of highlighted in the American Public Health Institute years ago, we show where your zip code is a better indicator of your health than your genetic code. So context matters. So traditionally what we've done in research and also practice is that we've looked at the people, not the context. So we're looking for the causes as indicated in this cartoon in all the wrong places. And it's not that behavioral risk factors are not important, but those drivers of those behavioral risk factors like poverty, access to care, racism are the key to addressing these things that are downstream. But really people find them, particularly behavioral scientists, because they're not trained in looking upstream, have had more difficulty in addressing these through interventions. So let's talk a little bit about terms. I know Mr. Barbosa mentioned some of these. Disparities is really just differences, although we've been documenting those differences for many years. We haven't always thought about them in the context of an equity lens or frame. In considering these both systemic and unjust, that's really the difference between disparities. Disparity just says it's a difference, as we know, but when you use that equity lens, the goal is that these are unjust and unfair, and they should not be there. They're unjust and they're avoidable. And so if we think about achieving equity, really everybody has that opportunity to attain their full health potential, and no one is disadvantaged from achieving this because of his or her social position. Social determinants of health is really a place-based definition of this frame, where people are kind of in place where they are born, live, age, work, and play, and worship, and they have unequal access to these factors, things like access to qualification, access to unequal employment, discrimination based on social status, and other factors. And then structural determinants are really those drivers. And so although we've talked a lot about social determinants of health within public health and how do we address social determinants of health, many researchers are thinking, you know, how do we move towards the structural? Because now we're talking about unequal distribution of power, prestige, resources among different groups within society. So structural determinants drive those social determinants. It's very similar to these differences, health disparities. We just see the differences. Inequity says that they're avoidable and unjust. And I think it's the same relationship when we talk about social determinants. Social determinants move beyond those behavioral factors to say that context matters, but structural determinants really get at the idea that these things are rooted in differences in an unequal distribution of power, prestige, and resources within society. I'm part of the center at UIC for Health Equity Research, which is a center that's focused on structural violence. And so structural violence really takes this to yet another level to think about this unequal distribution as being violent to certain populations that are disproportionately impacted by this power differential. And so it causes preventable suffering. So we can talk about something being unjust, but again, using this equity frame and a violence frame in the context of structural violence is that we think not only about interpersonal violence, but the idea that systems, policies, structures are violent and they cause preventable suffering for certain groups as compared to others. So what are the root causes when we talk about power and privilege? And this framing can be used not only in the UX context, but also across contexts. So when we think about the root causes, we can think about this perspective of, colonialism, the idea that within the US society, structural racism is not new. It is in our public policies, our institutional practices, our cultural representation. When you look across sectors, the media, in healthcare. And so the idea is that we have this history and culture that advantages whiteness and disadvantages people of color. And again, this has persisted over time. White privilege, again, is something that we can't see. And so the idea that white privilege, these historically accumulated benefits, they're rooted in our society. And it's not only one-on-one, again, it's in policies, institutions. And so that's what makes it very hard to address in some ways, because it's in everything: home ownership, retirement benefits, wealth, as was mentioned from the other speakers. And in some ways, it's rooted in white supremacy. And so the belief system from a certain extent keeps these types of disadvantages and structures in place when we think about this overarching perspective that moved from one that traditionally was thought about in genetic superiority, but also can be, manifest itself in superiority when it comes to intelligence, or superiority when it comes to moral standards. So even though we don't always see white privilege and white supremacy as being behind some of these structural inequities, they're rooted historically in white supremacy and white privilege. So Kamara Jones, who was at the CDC years ago, published an article in the American Journal of Public Health called "Racism: A Gardener's Tale." And this kind of frames like, who is the gardener? So government, who has the power to decide? Companies and corporations, where we have a gardener that they may have the power to decide, the power to act, may control resources. And it becomes dangerous when it's concentrated in one group and not equitably distributed. So we have personally mediated racism. So these are things like microaggressions, things that may be one-on-one. and they are condoned by societal norms. And in many cases, we don't always realize that we are playing a role in this. So it can be an act of commission or omission in the sense that we don't realize that we're engaging in some ways in these types of approaches. And then internalized racism, or what some people refer to as self-hate. So the idea that these systems of privilege make people feel less valuable, and so it erodes individual self-value and undermines things like collective action. And then institutional racism, or people talk about systemic racism. Again, those things that are rooted in structural barriers. It's historic. It includes things like white privilege. And years ago, which was very evident, this idea of biological determinism was there, but in more recent years, that's been less at front and center, but these differences in policies still exist. So the National Institutes of Medicine produced a report on racial discrimination and the pathways by which they impact health. And so there are two main ways when we think about racial discrimination and health outcomes. One is differential treatment on the basis of race that disadvantages a racial group. So disparate treatment, studies have shown how racial discrimination limits people of color's access to education, employment, resulting in social and economic consequences, but also treatment on the basis of inadequately justified factors other than race that disadvantages a racial group. So we know that incarceration is rooted in racism, but that also has implications in general for people that are incarcerated. So it's not necessarily just the thinking that, okay, Black people that are incarcerated, but because people of African descent are disproportionately incarcerated, any policies that discriminate against people that are incarcerated will disproportionately impact people of African descent. So there's two ways. One is sort of that direct way, and then also that indirect way. So if you think about this, it's at all levels, as was mentioned before. So the National Academy, I said the National Institutes of Sciences, but it's the National Academy of Sciences. So we think about things like immigration policies, incarceration policies, predatory banking, at the community level, differential resource allocation, and racial segregation when it comes to education. Institutional level, hiring practices, promotion, over-evaluation of contributions, overt discrimination, implicit bias, internalized racism, stereotype threat, and people embodying, as Dr. Obasanjo talked about with higher income individuals, the belief is that their stress from discrimination gets under your skin. It's actually embodied in your physical structure, that it puts you at a disadvantage when it comes to health outcomes. So when we think about, and can you see my screen? I just want to check in and make sure that you can see my screen.
Yes, you can.
You can, okay. The Barhigh model, the Bay Area Regional Health Inequities Initiative, and this is sort of a common framework when we think about upstream and downstream. So traditionally, like I'm trained as a nutritionist, we always looked at, dietary behaviors, those downstream, and then whatever is sort of further downstream from that. So how does diet impact cardiovascular disease and morbidity and mortality related to cardiovascular disease, diabetes, but not thinking about these things that are upstream. So where are we looking when we want to address not only the disparate impact when it comes to COVID, but everything. As Mr. Barbosa mentioned, this is really a layering, and Dr. Obasanjo mentioned, this is a layering on top of things that already exist. So it's critically important that we move upstream to think about institutional inequity, power, structural determinants that are even further upstream, differentials in power that will help us address these downstream behaviors that may be more proximal. So one example of this is cardiovascular disease. I know many people have probably seen the fact in the media that cardiovascular disease can put people at risk for more severe illness when it comes to COVID. This was published by the CDC in 2018, and it showed that death rates declined more slowly for Blacks than whites over time. This was between 1968 and 2015. The Black and white mortality ratio increased over time. So many times we think about, 1968 in rates that were, cardiovascular disease rates that were present in 1968. But although we see this decline, both for things like infant mortality, cardiovascular disease, this Black-white mortality ratio, for certain things, it's increased over time. So although everybody is getting better, the gap is not necessarily getting better. It's staying the same or getting worse. And then in 2015, death rates for Blacks were higher than whites in most states. So 68%, so that was the percent of the states with higher cardiovascular disease mortality rates for Blacks than whites. Because my interest is diet, these differences in health outcomes are rooted in dietary disparities, both dietary intake, dietary behaviors, dietary patterns that exist. And again, these disparities in diet are both systemic and unjust. So the idea that these disparities, or the causes of these disparities, I guess I should say, are rooted in this idea of systemic in differences in structures, and we see it manifest itself in behavior. This is data from NHANES. It's fruit, consumption of fruit by race and ethnicity among US adults from 1999 to 2012. And again, we see these disparities between white, Black, in this case, Mexican-American populations, and these disparities have persisted over time. But I think what's really important to realize is that although these disparities have persisted over time, these differences that are created by inequities in structures, that for many things in the 60s and 70s, and in even some cases in the 80s, but mainly the 60s and 70s, you have for several health outcomes, the Black and white gap was not as large as it is now. Breast cancer, and I think that's important to think about what is, things were bad before, but although we think about them getting better, in some ways they're actually getting worse. So this is a framework that was developed to think about equity in diet. How do we develop things like food retail in communities? How do we look at the promotion of healthy, unhealthy products as compared to healthy products? So this is an example of diet, but diet is just one of these cases. So how do we increase healthy options within communities to make sure that people have a lower risk and able to eat healthy to address underlying causes of disease, but also to increase and promote healthy immune function? How do we reduce deterrence to healthy behaviors? How do we improve social and economic resources for people to be able to access healthy foods, purchase, so things like job training, access to employment. And then how do we build community capacity and make sure that communities are at the lead, that we have strategic partnerships, and that we're developing a community infrastructure that is supportive of health. So I know we talked about, and for the sake of time, I won't go in depth with some of these because they've been covered, the racial wealth gap, which is at the root of this. But I wanted to highlight this layering when we think about inequity in social and structural determinants of health. This is probably not even a mile from where I live in Chicago on the South Side, which is a wonderful place to live when you think about cultural resources. But it's also been disproportionately impacted by disinvestment. And this is after where you had the social unrest that occurred. And so when we think about this layering, people are already at a disadvantage when it comes to COVID and less resources in the community, jobs, working at the front line, disadvantage when it comes to access to care and good quality care, at a disadvantage when it comes to testing initially. But then when you look at the inequity that exists within communities, both in retail as well as just the overall conditions that people are dissatisfied with, you have this layering. And so we need to think about how do we address this? It's not just COVID, it's not just health, it's not just deaths related to chronic disease, it's not just health behavior. It is really a very holistic assault. And I think the term structural violence really captures that. How do we think about addressing these unjust systemic inequities that exist through community investment, development of community infrastructure, and policies that really center on root causes versus just symptoms that manifest itself because of these things that are happening within society. And I'll stop there.
Thank you all so much for that information. So I will open the floor for questions. You can add those in the chat function. I believe we do have a few minutes for questions. So I don't see any questions, but are there any last thoughts from our panelists about the information we've talked about today? I know there is some great gems of this is more than just COVID. And I think understanding that is important. But any last thoughts, any last words?
What I just wanted to say is that from the presentations, you can see the overlap, that it's really the same things over and over again. And I think we didn't really, but we all presented, we all developed our presentation differently, but there's so much that there's something there that we really is at the root cause. And like Dr. Odoms-Young said, that we have to look at this not just as COVID or as one of those things, but there needs to be a review of really the society, what the bargain of society has been, how, what have we decided this society will be, an unjust one or a just one? And the system we're on now is an unjust one.
Mm-hmm.
Yeah, I think that's really important. If you look at the report from the National Academies of Science, part of, from the standpoint of a scientist or from the standpoint of a practitioner, we need to think about these things of using the evidence. It's not just things that people think, but they are scientific documentation by which these pathways, as Dr. Obasanjo talked about, epigenetics. So the idea that these things are, persist over time. And it's so important too, because what we have not documented is that it's not only impacting Black people, but it also, engaging in discrimination affects whites as well. There's been several studies in South Africa that look at the stress that when you have a society that has this sort of persistent racism that persists, it's important. It has a health impact on everybody. So some of these policies are not only, they're not beneficial just to the group that's at a disadvantage, they're beneficial to everyone. And how do we think more about how anti-racist policies can help society overall, not just this idea that it's targeting one group, it's good for everybody.
I think there's a question on stigma in the health system. And I think I will just try and answer that. And if either of you want to add to it, there's really documented stigma in terms of the health system. Everything from how people perceive doctors and physicians and health workers perceive Black people and pain. One of the areas this has showed up is that when the opioid epidemic occurred, it's kind of lessened. It hasn't gone away, but there was less of it within the Black population all over the country than the white population. And it was found that it was because physicians were not prescribing pain medication for Black people as much, because they had the idea, there was this idea that addiction is a Black problem. So if a Black person was in pain, they were generally not prescribed pain medication. It turned out to be a benefit in terms of the opioid crisis, because then you did not have the opioid epidemic affect the Black population as much as it could have. But that's part of it, is that this idea, we are all part of this society, right? And if you look at the implicit bias, even Black people have the implicit bias, because society tells us something all the time. It's all around us. So health workers, even the best of them, have those implicit bias. So as a Black person, you show up for the healthcare system, and there's some assumptions made about you, and you are treated along those lines. And so talking personally, right now with the COVID-19, my whole thing is that I do not want to end up in the hospital or anything during this crisis, because my feeling is that I'll be treated worse, especially in a crisis. If they have to ration health and I'm in the hospital, I feel I will be the ones rationed off. That might be right or wrong, but that is my perception of the health system, and that affects my behavior. If something happens, I will not go to the health system today, because I kind of feel that when there is a rationing of healthcare, I will not be the one that will be favored in that atmosphere.
Mm-hmm. I just want to add that the stigma is very real in terms of not only how people are treated, what kinds of options they're offered. Black men and women often are offered fewer medical interventions as options than whites who are having the same conditions. Oftentimes that's about price and the perception of the doctors and nurses on what the patient will be compliant with, and their perceptions on what that person's level of insurance is, without actually knowing. And that affects people across the gamut. And thank you, Dr. Obasanjo, for bringing up the perception. Is a wonderful study, and wonderful because it highlights some of these, how crazy racism is. That looked at the wimpy white boy syndrome, that in the NICU, so with preemies, so these are children who were born before term, that the white boys were held more often, received medication, received mother's milk more often than all of the other babies in the care, because there was a perception on the part of the nurses that they needed it more. So it extends to these places and extremes that just puts people at risk in so many places. And that's the same. I spent 9 years on the board of a hospital system, and so much of the work to make the system really responsive to the people of color who are walking through the door wasn't just about language and culture. It was really undoing some of what the doctors and nurses and other medical professionals had been taught through the medical school system and through the profession. Things that we would, really hard to believe. There's a perception that people of color, especially Black African descent people, have actual thicker skin than white people. There's a perception that they can take pain to a higher extent, and so some of that not offering pain medication or pain maintenance was about this perception that they could suffer more, they could take more pain, etc. And for a broken arm, you would think that the same interventions would be put forward. So there's quite a lot out there that we'd have to address in the stigma, because the relationships and the real lived lives that people have with their healthcare system, it shows them over and over again that the stigma that they have in their minds is more real than perhaps the rest of the world perceives.
I don't know if there's any data on that. I think right now there's a general just aggregation by race and ethnicity. The thing about COVID though, yesterday there was a governor that just announced, the first governor that announced that he had tested positive. Globally, COVID is actually turning out to be an equalizer in terms of its rates. It doesn't seem to have a particular, it hasn't gone down in socioeconomic level, and it's slowly getting there. The reason, apart from people that work in critical and essential jobs, most of the reason for that is that the first people to get it in most countries flew in. Poor people definitely do not fly around the world. So, for example, one of the first cluster was a meeting of a pharmaceutical company in Cambridge, Massachusetts. All the people in the room were high flyers, right? So they had the meeting, then the guy that brought it in came from Germany, they've spread around. So that has made it that you don't have that stark socioeconomic thing, but it's slowly getting there. So you find that presidents are having it all over the world, ministers. That has been the rate, just because almost in every country it flew in, and the poor generally do not fly around the country or the world for that matter.
And I just want to add that absolutely around the world, where the initial contacts have been at the higher ends of the socioeconomic sphere. In the US, we've seen the deep, and I'm from Cambridge where that company held their thing. We see a deep presence of this in the African-American community, where there are multiple generations living together, different socioeconomic spheres living together. But as always, people with more resources are also able to get away further, have more impact on how close they are to the disease. And so what we see in places like New York, affluence has been probably the biggest determinants of not getting the disease, because literally people could leave town, and they did. African Americans with means were able to leave town and not be in the spaces where they were more likely to be infected. So there is, if there is one stratification there, it is about those who are able to separate themselves from the general population. But that's the only stratification we've really seen around income in the African American community.
Adding to what Mo said, sorry, I'll give Angela speak soon, is the fact that even isolation, if you're in contact with a positive person, what you're told is to isolate. Most people cannot isolate in their house. You have to have a kind of have a kind of house in which somebody can be in a space and not interact with other members of their household. That's a luxury most people don't have.
Yeah, I was just gonna say, and I'm not sure if I can share it, but they have a map that was generated in, this is Chicago, and this is COVID cases by zip code. And so it doesn't have we don't have the income map layered on top of this. But when you look at the areas that are dark blue, at the bottom is the south side that I showed, 60620, 60619. So this is a difference by neighborhood. And this, because we have such high racial segregation in Chicago, is easy to layer as compared to some other areas. But you can see with the exception of some of these areas at the top, and this is near the airport. So part of it is where you look at the differences below is where you see those traditional inequities in outcomes. You see the same with COVID by geography.
And just to add that in Chicago, the African-American neighborhoods that are the affluent African-American neighborhoods aren't in those spaces where you have the higher rates. Again, if you can separate, if you can isolate, then you have a better chance of not catching the disease. And really important that for a lot of folks who are being asked to isolate, when you take that test and you're still waiting a week to 10 days to get a result, you're going back to really to conditions that don't allow you to really keep other people safe. And that's where we see. There's a tragic story of one of our state representatives in Massachusetts. She lost her grandmother, but people came to the funeral and 20 people in her family were then infected. She was hospitalized, her father was hospitalized, both of them thankfully survived, but it's also the cultural traditions that put people at risk that we've seen around the world when there are these pandemics that we have to make some changes in culture. One of the things that we're struggling with now is that same cultural traditions that sometimes we don't call cultural traditions because they're part of what we see in the mainstream white community, and thus people don't call that culture when it's done by white people, but it is. That's also starting to put people at risk right now. So the places that, every summer you get together at the lake, that's a cultural tradition that is putting people at risk right now. The 4th of July barbecue with 120 people, that's a cultural tradition that's putting people at risk right now. We don't call those things those, but that's exactly what they are. And so this is a challenge for a lot of folks because you're asking them to do something different than what they've always done. And so we have to make sure that we are putting forward and going with an open heart that says, yes, we are asking you to do a hard thing, but this is really important.